Virtual. Okay. We're good?
Go on camera.
Yes.
Good evening.
Good evening.
Hello.
Good evening and welcome to the third Cumberland County Board of Health meeting in the year 2022. Today is March 15, 2022. Remember to please mute your electronic devices so as to minimize disruption during the meeting. Thank you for taking time out of your busy schedule to attend this meeting. We will now observe a minute silence to unwind and focus on today's agenda. Thank you very much. To establish a quorum, I will call on the names of board members I see present. Please let me know if I unintentionally leave out your name. I have Dr. Cancel here. I see Dr. Jennifer Rebolote, John Latch. I see Dr. Kent, Dr. Alsadi, Mr. Bart Pfizer, and Dr. Cynthia Makafakini. Are we missing anyone else? Okay, thank you. May I please ask the Department of Health staff members present to please very briefly introduce themselves?
Jennifer Green, Health Department Director. Cindy York, Accountant.
Kelly Smith, Administrative Assistant.
Ashley Curtis, Deputy Health Director.
Crystal Benson, Director of Nursing.
Thank you. And I see it, Dan Miller. Thank you very much. Please take a look at today's agenda for today's. Take a look at the agenda for today's meeting. May I please have the motion to approve the agenda?
I move that the agenda is be approved.
Okay. Second.
Second.
Thank you. All in favor?
Aye.
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 Thank you. I believe you all had the opportunity to go through the February meeting on pages 2 through 5 of your packet. Do we have any comments or correction to the minutes? If none, may I please have the motion to approve?
Outside the motion to approve.
Thank you. Second. Thank you, Dr. Council. All in favor?
Aye.
Aye.
Thank you very much. Next is the approval of the fiscal year 2023 budget. I will call on Mrs. Candy York to please present the budget for the fiscal year 2023. Thank you, Mrs. York.
Good evening. On the screen is the budget presentation for fiscal year 2023. This page just represents the current Board of Health members and position you hold on the board. And the bottom of the page is a list of the senior leadership team at the health department. Next page. In the packet, there is a letter from Dr. Green, and I will read this. It says, Dear Public Health Board members, Cumberland County Department of Public Health remains committed to our mission to provide high-quality service in a professional, efficient, and fiscally responsible manner while improving the health of Cumberland County. Our mission is to have healthy people living in a healthy community. Our aim is to improve the health of our citizens by offering health education, clinical, and preventative services. Public health staff identify key community health issues and health hazards, as well as enforces laws and regulations to ensure safety. Health equity remains at the center of our work as we work to reduce health disparities and improve health literacy. We shift into the new phase of the COVID-19 pandemic. Our COVID-19 response efforts to health and safety of our community. I am pleased to present for your consideration the fiscal year 2023 budget request. The budget represents revenue and expenditure projections to support public health programs and services. The total budget is in support of continuing operations for 30 programs and administration. Expenditures are estimated based on prior trends and known increases to retirement benefit contributions, medical insurance benefits, and operating expenses. Revenues are projected with actual state allocations and grants received, as well as Medicaid and fee revenue estimations. The recurring budget request for fiscal year 2023 is $27,036,356, which represents a 3.6% decrease for the current year's revised budget of $28,037,950. Current year budget includes some COVID-19 funding that is not a recurrent allocation. The department is requesting supplemental funding to support a pilot program to provide patient transportation and 2 new positions. Upon your approval, this budget request will be presented to the county manager for recommendation to the Board of County Commissioners. Thank you for your consideration, Dr. Jennifer Green. The first page here represents the revenues. I've listed the actual revenues earned in fiscal year 20, also fiscal year 2021, what the current budget for fiscal year 2022 is, and then the next to last column is the requested amount for fiscal year 2023, and then the percentage change is representative of change from the current budget for fiscal year 2022 to 2023. I'll note some variances. On the state and federal line, you'll see that there is a 12.4% decrease in fiscal year 2023 requests. This is due to COVID-19 allocations that were awarded in fiscal year 2022 that allowed for rollover into fiscal year 2023. The amount carried forward will be the balance of remaining at the end of fiscal year 2022. So for 2023 requests, I did a projection based on current expenditures and what we anticipate spending through the end of the fiscal year, June of this year, and then budgeted the remaining amount in fiscal year 2023 for all the COVID funds that were, we have been notified at this point that will be able to be carried forward in the next fiscal year. On fund balance, you'll see that there's a reduction of 57%. I reduced the requested allocation from the fund balance usage that was previously used to support temporary case management, for care coordination, and pregnancy care management program. The revenue for those 2 programs have increased to the amount that is allowed for the temporary case managers to almost 100% be funded with their actual per member per month revenue that we actually receive. I didn't put a note on it, but I just wanted to draw your attention to the Medicaid fee for service that you see there's a 9.6% increase. This is primarily due to the Medicaid cost settlements, non-federal share. The way with the new prepaid health plans for Medicaid, we have to set up for our cost settlements, instead of being an annual settlement, we'll actually receive quarterly settlement. As part of this process with the state and the PHP, we have to make a quarterly payment to the state of what they consider the non-federal share of the Medicaid cost settlement in order for the PHPs to pay us the cost settlement with the federal share. So having to budget that revenue to be able to pay that extent that we will be reimbursed for, it's kind of a complicated process. That did drive the actual revenue for Medicaid fee for service up to the 9.6. That's what that represents. As I said previously, for Medicaid case management, there's a 9.4% increase, and that is for the pregnancy care management and care coordination. We also refer to them as CHARP and CMARC. Years call them that. Those case management programs, we have seen an increase in revenue collections in last fiscal year and also this fiscal year. So I was able to budget accordingly for that. And I'll pause there to see if there's any specific questions in reference to the revenues. The next slide is actually just a real quick graph just to show you how the breakdown of the revenue, what percentage is covered by which type of funding. You'll see that we still have 39.96% of county funding to support our programs. Of course, followed by state and federal at 34.69%. And then below are all the Medicaid fee for service, case management, local sales and fees, grants, and then the fund balance of the bond. Next, we'll move on to the expenditure breakdown. I've listed the expenditures based on the program type. There again, I've listed for fiscal year 2020, actual for fiscal year 2021, what we currently have budgeted for fiscal year 2022, and the amount that we're requesting for fiscal year 2023. For administration, you see that we had a 3.6% decrease. This is due to the ARPA Workforce Development Funds that were also derived from COVID funding that have been budgeted in fiscal year 2022, and the amount that's being budgeted in fiscal year 2023 is based on the projection of what we anticipate spending of the allocation, and the remaining amount will actually roll forward into FY 2023. This is an estimation, so later in the fiscal year, when the fiscal year starts, once we receive the actual figures that we extend in fiscal year 2022, you may see some adjustments be made to that once we receive the official contract agenda from the state that reflects the allocation. It will reflect the remaining balance of actual in case we do not spend all of the funding that we or estimate that we'll spend this fiscal year. Clinical services, also, there's a 9.2% decrease for fiscal year 2023. That is also due to COVID-19 funds that we anticipate some of that will be rolled over, but it will be less based on what we've actually spent this fiscal year. For school health, there's an actual increase from last year or for the current year of 10.2%, and that is going to be tied to the ARPA school workforce development funds that we've received from the state. And then, as I had said before, for the Medicaid case management, there is a 0.8% change. I did reduce the temp budget. Of course, we're not using fund balance for pregnancy care management, only for care coordination. And then I budgeted based on the number of temps that we've had hired at any given time to more accurately reflect the expenditure we actually anticipate. And this year and at the end of last year, actually, it's been hard to recruit temporary case managers. Or once we do hire them, they end up finding permanent employment, and so we have a high turnover in that area. Then, I'll pause again and see if there's any questions about any of the expenditures. WIC. The WIC, that is actually going to be due to the retirement benefits and the for expenditure purposes for retirement benefits and right now medical insurance increase. The retirement benefit matching percentage went from 10.41% to 11.16%. And then the medical insurance contribution the county has put in was previously $9,200 per employee, and now it's actually going to increase to $10,301. And then the revenue the expenditures are budgeted and the revenues are based on the actual allocation that comes from the state, so that matches that as well. So they did receive a little bit of an increase this year. Moving on to the next page. I included this in the packet is the expenditures by actual account description. The salaries regular are based on the permanent employees that are budgeted. As of right now, this figure does not reflect any kind of adjustments that will be made based on current pay plans that we may have for certain categories of positions. And of course, there is some extra funds in there for any kind of cost of living. Of course, we don't do any of that at the department level, Until the Board of Commissioners will make that recommendation and pass and approve that, then of course we would have to make adjustments to our salaries at that point. We have salaries on call. This is for our environmental health and our epidemiology staff. They are actually on call at night and on weekends on a rotating basis, and so they are actually paid for that time. And then, like I said before, the retirement contribution has increased this year, so it went from 11.41% to 12.60%, and that's based on that percentage against the salary for each employee. And then medical insurance, of course, increased from $9,200 to $10,301 per employee. Going down into the actual operating expenses, a couple I want to highlight what they are. So down, you'll see contracted services, that there's $5,505,847 in contracted services. Of course, that is a very large amount. I wanted to bring attention to what that actually represents. $4,431,667 of those funds are actually tied to COVID temporary employees for the different various types of money that we've been allocated. The remaining, of course, is tied to just normal operating. We actually have a contract with the Sheriff's Department for our deputy that serves as security of their health department. We fund HealthNet for adult health primary care that they offer in our building. We also fund 7 Wade Health Services for adult health as well. There's roughly around $200,000 of those contract funds that are tied to the opioid grant that we received that actually is going to North Carolina harm reduction. And then the others are just normal operating things that we have, like shredding services, our language line that provides interpretation for all funds. Well, it includes Spanish, but we especially use it a lot for any population that we have that speaks a different language than Spanish. Things such as our HIPAA security audit and those types of things. The insurance and bonds, of course, that is representing our actual malpractice insurance that we have. The executive policy we have for board members and administrative officers. Also with property insurance, general liability, and then auto insurance that we have for our mobile unit and for our one agency vehicle we have. And then at the bottom of the operating, you see that we have Medicaid cost settlement, and that's what I was referencing earlier, that we have to make payment out for the quarterly non-federal share of the Medicaid cost settlement. And then, of course, later we have our building debt, of course, which is the contribution that the health department show the expenses toward the actual cost of the building. Operate out of. Then I'll see if there's any questions about any of the other line items that I didn't highlight. We can move to the next page. This is just a graph real quick to show you the expenditures, to show that 43% of our budget actually does go to support clinical services, which are health clinics within the agency. And then we have administration, then school health for our school health nurses, of course, and then WIC is 10%, followed by Medicaid case management at 8%, and then environmental health is 7% of our actual expenditures. On the next page, I just included a copy of all the different types of positions that we actually have funded. These are just permanent positions that we have. This does not count any of the temporary staff that we hired on, which of course are a lot of the COVID response. We have 258.5 actual positions with an FTE of 249.92. We have our school health nurses. There is a big portion of those that are actually 35-hour-a-week employees, and so they actually are 0.74 FTE. That is the big bulk of what makes the difference between the number of funded positions and the actual FTE amount. So I listed 5 actual position types and the number of FTEs we have at each type. The next page. I'm providing a breakdown of the fund balance. Since we're asking to appropriate fund balance, I want to be able to see the actual balances that we have projected. The consolidated agreement we received from DPH requires that certain funds be kept separate in the county's financial statement. These programs are care coordination for children, we also call force CMARC, and then child health, family planning services, pregnancy care management, we also call CHARP, and then maternal health. At the beginning of the fiscal year 2022, you see collectively our balance of $6,052,823. Based on the earnings in these particular programs and the expenses that I project for the year, I'm projecting that at the close of fiscal year 2022, we will actually gain and we'll have $7,226,975. And so we are requesting to actually appropriate and use $251,218. Of this, $199,322 is going towards the debt service, the $500,000 that we have for the building. And then for TC4C, Care Coordination for Children, or CMARC, whichever one the names we call that program, temporary staff of $51,896 that we anticipate needing to cover that program's needs. The other programs, if they earn excess revenue, it's not required to be assigned or held separate in the county's financial statement. So therefore, any excess funds, of course, do offset and reduce the amount of county funds that actually support the programs. We are required to keep an account of that, but not keep it in the county's financial statement. So I actually keep a separate spreadsheet myself from year to year that actually shows the actual earnings of fund balance of other programs, although, like I said, it's not recognized at the county level. And I'll pause and see if there's any questions about the fund balance, if I can explain more in detail. Okay. I'll move on to our actual supplemental new requests that we're asking for. As I said previously, we're requesting 2 new positions. We would like to get an office assistant for our environmental health on-site department. Currently, we operate that office at the historic courthouse with 1 permanent office assistant, and we have a temp clerical. In the past year, we've had turnover and hired 5 temps. They end up finding permanent employment and leave. So as soon as we get them trained. And so also the rate that the temp agency offer, of course, is not very high. So of course, they're always seeking to find permanent employment. We currently have $28,300 budgeted for the temp employee. A new position with fringe benefits will cost $47,268. So it only require $18,968 of additional county funding to support this request. We're also asking for a public health educator 1. And at the bottom of this page, I'll read to you our justification. Health educator position is needed to fulfill program objectives. Result-based accountability structuring requires additional programming efforts and greater demand on partner collaboration. Staff will use supportive software to strategy map and data chart project health priorities with results, indicators, programs, and performance measures. This process is a part of the public reporting required by state standards and aligned with Healthy People 2030 response. Additional staffing will also allow for continued support of municipalities within Cumberland County for the nearly 333,000 residents. That position does not have any revenue that could be generated from it, so it would, in fact, incur the county a cost of $52,210 for salary and fringe benefits. Any questions in regards to the new position? Okay. The next request is our supplemental request for patient transportation. The health department continues to struggle with high no-show rates in all clinics. The rates always fluctuate from week to week and clinic to clinic, but range between 15% and 30%. Recently, the health department began collecting social determinants of health data for all patients that present for service. In the brief period of data collection, 8% of patients reported They have in the past 12 months experienced transportation issues which prevented them from attending medical appointments. The health department would like to pilot a transportation program using Uber Health or Lyft Business for health care. Both services are HIPAA compliant, offers real-time tracking, same-day service, and offers reasonable fare prices. With this service, we will be able to offer same-day appointments to all patients, but this would especially be helpful when attempting to treat communicable disease patients as soon as possible. The service offers data metrics for tracking costs and duration of trips. The health department has requested $50,000 to start a pilot program offering transportation services to medical appointments at the health department. If approved, staff would utilize the data metrics to report as requested to county management, Board of Health, and Board of County Commissioners on the effectiveness of the program to reduce no-show rates and to lower the number of patients reporting transportation barriers. If there's any questions, I'll be happy to try to answer those. Well, first let me just say that we estimated the trip to be, we just did a roundabout number of $25 per trip. We think we could actually serve 2,000 trips. It may not be unduplicated patients, but 2,000 visits. And of course, this information would have to be tracked. Once we got real live data, we're able to report actual numbers. All right, and the last page is just a summary of our actual total budget request. So for our recurrent operating request, we're requesting $27,036,356. The supplemental request total $149,478 for a grand total request of $27,185,834. If you have any questions, I'll be happy to answer those and provide clarification.
Do we have any comments, any questions, please?
Outside speaking, for the transportation, is that something that will be handled internally, or are you going to contract it out?
Our intent was actually to handle internally with our staff. We would feel that we could have hands on it and be able to be effective in providing transportation. Like the same day is what our goal would be if we have people calling in and we have those slots in any of our clinics. That way they we get them seen right away.
Yeah, and the transportation itself, we would contract that and work with a contractor MOU with either Uber or Lyft or a similar company. But the tracking of the data, both of those companies have dashboards that you're able to utilize to be able to manage the trips, and we could do that internally.
Thank you.
Department will handle that.
So we have Candy's team is the management support team, and we also has a billing team. And between the two of those teams, we've identified a few positions that we think will be able to handle that within the health department.
Anybody else have any questions? Any comments for Mrs. York? Thank you very much, Mrs. York. May I please have the motion to approve the budget?
This is Board, I approve. I'll make the motion that we approve it.
Thank you. Second?
Second. Carter Flashman.
Thank you, Dr. Fleshman. All in favor?
Aye.
Aye.
Thank you very much. Okay, moving on to item 3 on the agenda. There is no public member registered for public comment. So I will call again on Mrs. Candy-York to please present the financial reports on pages 6 through 11 of your packet. Mrs. York, please.
Thank you. On page 6, we have the statement of revenues and expenditures for the month ending February 28, 2022. At the close of the month, our revenues exceeded our expenditures by $632,773.29. I will draw attention to the revenues, the line item that says due from state and school systems. The total revenues does include the revenue that is due from the state for February expenditures, and also the amount that's due from the school system for the 14 school health nurses that they actually fund. We receive those after the fact. Including the ones that we fund as well. There's around 40.
Yeah, okay.
Yes, I just add them together in my head. On the next page, we have the expenditures by program. As requested last month, I broke this down to actually remove the COVID-19 expenditures so that it would be a more accurate reflection of the percentage of budget that we've actually spent. Without the COVID funding included, we've expended 51.13% of our budget. Of course, if we were spending at 100% at the 8 months of the fiscal year, we would have expended a little over 66%. Most of this is tied to staff turnover. We currently have around 47 vacant positions that we're recruiting and filling for. Also draw your attention to a couple of fund items that we really haven't spent a lot of that could be also driving that number. The child fatality prevention, which is about halfway down, it's got an allocation of $12,589. These funds are always spent usually in the spring. They are driven by requests from the Child Fatality Task Force. They actually meet and review infant deaths and make a determination on items that are needed. A lot of times it would be things such as the pack and plays. They determine that children have a safe place to sleep. They also do monitors to parents so they can hear their infants. And then we've done some things also for younger children that have asthma. That's been the past couple of years, the expenses that we've actually expended. So I'm looking forward to the requisitions on those expenses so that those funds will be spent before the fiscal year ends. A little farther down, you'll see the comprehensive opioid grant. We're a little low on that. Unfortunately, the coordinator we had in position had left us a couple months ago, of course, so we have the lapsed salaries from that position. And in addition, without the coordinator, it's been hard to do some of the media campaigns that were also budgeted, so we're short on spending in that program. Positive parenting program as well. We've had a vacant position in that department for a pretty extensive period this year. I think we've got someone selected and we'll be filling that. And then some of the, because of COVID, it's been hard to actually hold some of the programs and recruit some of the actual providers in the region that we serve. Like I said, they have come up with a plan to spend some of those funds and get the materials and training out to the different communities. So more of those funds will be spent before the fiscal year ends. Partnership for Children, of course, this was a new program for us this fiscal year. Took a while also to get off the ground, hire the different positions. There's 3 positions tied to the program. We have 2 of them filled, and I think the other one is selected now to make 3.
Yeah, we're working on it.
I'm working on it. Okay. So we'll also be moving forward with spending some of those funds. And then the Advance in Equity, the last one, of course, we don't have a lot. It was an allocation received late in the year. There again, same thing. It includes expenses for salary and for benefits for positions that, of course, had to be established and recruited for. The total, including the COVID, we've only spent 43.14% of our budget. But there again, those COVID funds will roll forward into fiscal year 2023. Any questions about any of the expenditures? Okay, we'll move on to the revenue. First, we have our state and federal allocations. On this, I also backed out the COVID funds to represent just the actual regular recurring state allocations. So we have actually collected 49.3% of the budgeted revenue for state and federal allocations. This, however, only does represent funds that have been earned for July through January services. As I said before, The state and federal allocations are always a month behind. We get paid the following month for expenses incurred. So it really represents 7 months versus 8 months of revenue collection for state and federal. And then below that is the COVID collections, and there again, those are based on specific services that we can do, temp staff that we have employed, and of course, we're trying to get up and going the RBUG COVID regional workforce initiative, so that also will soon be, we'll see some funds being spent in that category. The bottom of the page are our grants. And so we have extended, or we've recognized, 23.85% of our grant revenue. I'll draw your attention to the Cumberland County School Health, where we've only showed 19.55%. That is based on the invoices that have been submitted that they've actually paid for. We bill them a couple months at a time, sometimes it's quarterly. And so we've only received the first quarter revenue. They will pay us, so we always get those funds, but just sometimes a little lag. And then the Partnership for Children, of course, you see it's a low collection based on getting that billed, or getting those positions billed and actually incurring some costs. And there again, we also receive those funds after the expenses have been incurred. And I'll show you a Cumberland Community Foundation, which is the actual first grant listed. I realized after I printed the packet that I don't know what I did to the formula on that line, but we actually, we've earned $32,000 of the 40, which is the allocation for this year. So we've actually earned 79.18%. The total at the bottom of the 23.85 for the total earnings is correct though. Moving to the next page for our Medicaid revenues. We actually earned 67.24%. So looking at 8 months into the fiscal year, we've actually earned where we should be. I'll draw your attention to the case management fees for the bottom of the grid, where we've earned $1,558,367. You see that's 80%. This is where I was talking earlier in the budget presentation, how we've actually earned excess revenue for those two programs. When I was looking at the numbers of for members for each one of the programs, during this fiscal year, they have increased from what we were receiving last year. I haven't been able to determine why that is. It's just a switch over from being paid from PCNC to actually now being paid from the 5 PHPs that actually have members. I don't know if they have recruited additional pregnant mothers and young children 0 to 5 for that program as part of their initiatives of the PHPs. But like I said, we have received additional revenue, but it is based on when we have additional enrollees served. Okay. Below that is our fees. We've actually only recognized 46.45% of the budgeted fees, which includes self-pay payments for services and also insurance collections. The first line, I just want to draw your attention to express care fees. I just want to sort of say that is actually for immunizations. I know it's titled, it's just the way it's titled in the actual ledger, but that is for immunization, and so that would be for self-pay or insurance collections for that program. The communicable disease toward the bottom, where we have collected $33,548. That is actually due to being able to bill for uninsured patients that received the COVID vaccine. We are actually able to bill for the vaccine and the administration charges to HRSA. So that's what's driving up that revenue collection. And then pharmacy services, I just want to give an explanation because I'm not sure if everyone knows. This is actually a reflection of the charges from the clinics for the medications that they actually requisition that are delivered on the clinic to a patient. So it's not an actual payment from a patient to the patient. Our pharmacy, they do not pay for the medications when they use the pharmacy in our building. But the clinics themselves do get billed so that they can recognize the cost in the actual program that actually was incurred. The next section is our fund balance and county funds allocated. We have $201,589. That's actually our building debt so far for the 3 quarters we've paid for. And then finally, at the bottom of the page, I'll draw your attention to that we have earned 45.4% overall of our budgeted revenue. Without the COVID funds included, we've actually earned 51.22% of the revenue that's been budgeted, which coincides with our actual expenditures. Moving on to the next page is our accounts receivable report. That's broken down by program type and also by payer source. And then last page is our private pay, self-pay aging report. It's broken down by clinic and then of course by agent. And I can answer any questions that you may have about any of the reports presented.
Thank you, Ms. Cynthia. Do you have any questions or comments for Ms. Cynthia on the financial reports, please? If not, I will call on Dr. Jennifer Green to please present the external reports and audits, and then move on to the director's updates and upcoming events. Thank you.
Thank you. So you have two external reports in your packet. The first one, beginning on page 12 of your packet, is the external report for our WIC audit. So we get a WIC audit, and then every few years, and then in the interim, we get a monitoring report. So the results of the WIC audit are included in your packet. There was a corrective action plan that we are already addressing, and that is due by the end of this month. And so that is fairly common for WIC audits because they're extremely extensive. They want to know how every penny is spent and make sure that every line item is correct. So just for your knowledge, I'll highlight a few things about our WIC offices that you find in the report. The first is on page 13. They identify some of our program strengths, including that when they come on site with us, or this time it was virtual, that we were able to provide the documents that they required in a timely manner, partly because of the work of Candy's team and our timesheets and our time and activities were well organized, and that we were flexible and accommodating with the work that we've done. So a few pieces, and this will give you an idea of how WIC works. We get a report out on the application or the application process of how people apply for WIC, and then if they have to transfer their certification from one WIC office to another, we get monitored on that section. On page 14, we get monitored on civil rights, meaning do we process things in a non-discriminatory manner and in compliance with the eligibility requirements for the state. And then we get monitored on our fiscal management, and again, that means whether if we bought a breast pump, it was keyed to the right line item, and there are several different line items there. Our policy and procedures, the completion of our nutrition assessments, and making sure that we assess each WIC client appropriately for their dietary needs, their social determinants of health, their any other measures. And then we also, on page 16 of the report, get monitored on our plan of care. So when patients come in, or WIC clients come in, making sure that we have the appropriate plan of care for them, making sure that we're administering the correct food packages for WIC for them. We also, on page 17, get monitored on nutrition education, making sure we're applying that appropriately, and then breastfeeding support and breastfeeding promotion and support. So in each of these areas, they do chart reviews, review our electronic system called Qrmd, and then there are minimum standards and then required actions of us to take. And so those are due back in writing. Some we're able to correct on site, and then those are due back to the state by March 28th. So we have, we're in the process of completing that now by the deadline, and we will be able to meet that. The second audit report is our Women's Health Monitoring Report. So this is a report that includes our maternity clinic and then as well as our family planning clinic. Betty Cox is our women's health nurse consultant. We did not have no corrective action plan for this, so we do not require any additional documentation to be submitted to the state. You'll see on pages 19 and 20, the 19 through 22, all of the items that were noted, we were able to correct on site. Several of the items were due to, we do something in practice, but we don't, the policy may not reflect that, or we needed to update the wording. The old board members will remember in October of last year, we updated Title 10 family planning program at the federal level, had several changes, and that we brought to the board new fee schedule, or new updates to our billing guide based on updates to our Title 10 family planning program. So some of that is reflected here, that because they were new requirements, we needed to adjust the language in the policy based on those new requirements. So no corrective action plan, no additional action plan from the state for those. And then Miss Betty Cox has been with us for, as our state consultant for our women's health branch for many, many years, and was extremely complimentary of our staff and their ability to produce the documentation that was required. And in this, for this audit, it's very similar to WIC. They sit down, they spend several days on site with our staff, go through our charts, go through our finances to make sure that we're in compliance. So those are the two external reports that I have for this month. And then Kelly, if you will pull up our slides, I will do my director's update. And while she's doing that, are there any questions about either of those external audits?
This is Dr. Kearney.
Yeah.
I have a question. Were those new infractions, or did any roll over from the previous survey for the WIC?
These are, I'd have to go back, and the previous one was before COVID, and I think we've had one other one since I've been here. And I believe these are ones, I don't think any are the ones that we've had before, but I have to go back and do a one-for-one comparison. If you look through the report, they do a chart review, and if you're missing any single thing on a chart, it's noted. So I don't believe off the top of my head that these are any things that we haven't had before. These are new things, and I'll note that we've had several new staff in WIC. So some of these are, we had a new staff member that we might not have told a WIC client, or maybe not updated their immunization record. But I don't believe these are new from the previous site visit. But I can go back for the board and do a one-for-one comparison with our previous audit.
All right, thank you for sharing.
Okay, we'll do a few COVID updates, and then we will, I have a few other quick items on the agenda that I want to call the board's attention to. So the first is our COVID update. So since our last meeting, and I always put my disclaimer there that if you are watching this meeting a month from now, this information may have changed. So since our last meeting, the CDC has shifted away from the COVID transmission levels. So the board was used to me showing the map, the color-coded map of where we are in the county. It was all red at one time. The CDC has really shifted away from that and really thinking about the outcome and the impact of COVID on health and wellness and health in our healthcare system, rather than just the number of cases and our case positivity rate. That is still important, and I'll get to that in just a moment. And we do still utilize that map, but for a different purpose. So they're now focusing on severe illness, hospitalizations, and then making sure that we're protecting those that are most vulnerable in our community. So we still utilize, I have a note there at the bottom that doesn't really apply to our healthcare settings. The CDC has noted that they really still want us to use those community transmission levels, so the maps that we are used to seeing when we think about making policy changes for our healthcare system, or our healthcare settings, and long-term care facilities. So on the next page, this really just shows a shift in the way that we're looking at our metrics. So again, we're not necessarily looking at our case counts alone anymore, our case positivity rate anymore. It gets much harder as our cases increase, or it did increase, to track every single case and to make sure and every single test performed. And we really are shifting to look at what are our vaccination rates in our community, what levels of therapeutics we have available, what treatment options we have, and then again, the impact of our healthcare system. So as a result of that, on the next slide, they have transitioned to this new mapping system called our COVID-19 community levels. So they're broken down into low, medium, and high. So red, yellow, green. And you start at the front, at the first column of the chart. You first identify how many cases you have in your community per 100,000 in the last week. If you're fewer than 200,000, you have an opportunity to at least be in the low. If you're greater than 200,000, you're either automatically going to be either in medium or high. The next step is that second column where you determine the number of new COVID admissions to the hospital in the last week based on your population size, and then the percent of beds in the hospital that are occupied by COVID-19 patients. And then those are broken down into, based on that number, those percentages and those numbers, you're either categorized into low, medium, and high. So on the next slide, we have fewer than 200,000 cases. Sorry, Kelly, one more. Thank you. So we have fewer than 200,000 cases. So that puts us in that first row. And our new COVID admissions are less than 10 in the last week based on our population size. And then our new, the percentage of staff inpatient beds occupied by COVID patients is less than 10%. And so that will put us in low transmission levels in Cumberland County. So just to break that down just a little bit more, we'll go through this quickly on the next slide, Kelly. This chart shows the graph of where the CDC is pulling that data over time. So you can see that really first sharp peak was in last January. Then we see that really second large peak that was Delta, and then the really high peak was Omicron, and now we're coming back down. So we're right back around where we were with Delta not too long ago, if not lower than that. On the next slide, I want to draw your attention to our COVID vaccination rates. And I have highlighted here in the red boxes our vaccination rates for the overall population. We're about 60% fully vaccinated. And if you just pull out the people that are eligible, we're at about 65%. I'll note, though, that in that middle column, we have about 80% of our population, our total population, that's had a first dose, which means people are not coming back for their second doses. So we need people not to just get their first dose, but we need people to come back and get their second dose. And then on the next slide, I have a few items highlighted. This is our vaccination rate. One more slide for Kelly. Thank you, ma'am. I'll note in the red boxes, this is our booster rates, and we really need people to come back and get their booster. We know it feels like COVID is over, but it is not, and we need people to get their booster shot. We only have about 13.5% of our fully vaccinated residents that have gotten their booster shot. That number goes up if we look at people that are fully vaccinated over the age of 65, so about a third. But we still have some work to do to get people to get their booster shot. So on the next slide, this shows, based on all of those metrics, what people can do to protect themselves. So the CDC makes recommendations based off your community level for low, medium, high. We are in the low. So the focus now for us is on getting people vaccinated, getting people boosted, getting people tested, making sure they have access to that. And then I'll note at the bottom that the CDC still recommends that if you want to wear a mask at any time, you should and can wear a mask at any time you want for that extra layer of protection. And that people, if they are sick, if they have a positive test or they have an exposure to COVID, they should still be wearing a mask regardless of the community level. So if you test positive for COVID, you do your 5 days of isolation, you still need to wear a mask for your second 5 days. And the same thing if you're exposed. We want you to wear a mask for your during your quarantine period if you've been exposed to COVID-19. So that did not change. And I feel like that's getting a little bit lost here. And the other piece is this is different for healthcare facilities. So people can still expect when you go to your doctor's office or you go to the health department or to our healthcare system that you should wear a mask. And so our recommendation to people is continue to bring that mask with you so that when you walk into those places of businesses or a healthcare facility or a long-term care facility or congregate living spaces like our detention center, that you still have a mask with you and you're prepared. So a few other non-COVID topics for the evening. I wanted to provide the board an update about our opioid settlement funds. So in July of 2021, Attorney General Josh Stein announced a $26 billion agreement with communities that have been impacted by the opioid epidemic, and that includes all of North Carolina. And so this settlement was the result of proceeds from lawsuits with some of the big drug distributors, including McKesson, AmerisourceBergen, and then Johnson & Johnson. And so as a result of those settlements, the state settled, led by Attorney General Josh Stein, for $26 billion. So it's been a while since we've provided an update to the board about this, but the work is really beginning now to think about what are we doing with those dollars. And so the next step after that settlement was to develop an MOA between the state and local government. And that MOA dictates how those funds are going to be distributed. So those funds were, the MOA was signed by Cumberland County and, keep me honest here, Commissioner Council, but I believe all of the other counties in the state. And the funding is going to be distributed to all 100 counties and 17 different municipalities as well, based on a funding formula. So 15% of those funds are going to go to the state, 85% are going to go to the counties and municipalities. For Cumberland County, our allocation over 18 years is about almost $17 million. It's going to be a little bit front-loaded. We're not exactly sure what that's going to look like just yet. And we're going to be doing work in the next couple of weeks and months to determine how to utilize those funds. So the MOA that was signed has two options. One is for a local government to utilize some designated strategies, which I'll talk about in just a moment, to pick one or more strategies from a list of evidence-based strategies and implement those strategies. The second option is for local government to fund one or more strategies from a longer list of strategies, but to do that, you need to engage in a collective strategic planning process, including community members and stakeholders. So right now, the health department staff, along with county management staff and the commissioners, have been engaging in a series of webinars to learn more about the use of these funds, how they can be spent, what those strategies are, where they can be spent, how they can be spent. The monitoring on these funds is going to be significant and substantial. So we want to make sure that we get it right. And so right now we're in the learning process of how we can utilize those funds. And I'll be going to a meeting at the end of this month to learn more about how those funds can exactly be utilized. And so on the next slide, we just have a quick example of some things that can be supported. Evidence-based addiction treatment, recovery housing, naloxone distribution, which we already do that at the health department, post-overdose response teams. Some of that aligns with our opioid grant that you heard about, reentry programs, syringe service programs. And so you could pick, if you pick option A from the list of programs, and then there's a longer list in option B that you have to undergo that strategic planning process. So right now we're in the process of learning the details of the MOA, what the options are that you can spend money on before we You can't just, get the money and then start spending. You really need to go through a strategic process to make sure that we're spending money appropriately. So more to come on the opioid funding and opioid settlement dollars. Just wanted to provide a quick update there. For Qrmd, just wanted to make sure we kept this on the agenda. There's not much new to report here, except this is coming fast and furious. So hopefully by the time that we meet next week, we'll have an exact go live date for you where we will begin rolling out Qrmd. Right now, we are in the development phase and our training phase. We have identified super users at the health department that are doing their training sessions now. We are working on sort of building the infrastructure and making it customized to the health department, and then making sure we have all of those contract services in place before we go live. So including text reminders, phone reminders, getting our patient portal set up. We're working on an integration with the QuitLine. Right now it's in a separate system. So if we want to refer somebody that smokes to the QuitLine, we have to log out, go to a different platform to make that referral. And this, we can use some of our tobacco funds and our child health funds to actually fund an integration of those two systems to make it a seamless process for our staff, which will hopefully mean more people get referred and connected with services. So hopefully we'll have some more significant updates for you in our April meeting, including an actual go live date. But we want to make sure that the public is aware that this is coming in the next couple of months. And then the last thing I have for you is an accreditation update. So for our new board members, we are required, the health department is an accredited health department. We're required to be accredited by North Carolina state law. And the accreditation cycle typically happens every 5 years. So our last site visit was in 2016, and which means our new accreditation cycle started in 2017. However, because of COVID, all of the health departments in the state got 2 one-year extensions due to COVID. So that means our data collection really, it did not exempt us from doing the accreditation activities. We still had to meet all of the program requirements. It just means that we didn't have to turn in our documents right away. So that got extended from 2017 to 2022, meaning we're actually collecting for 7 years, which is a challenge in itself. And then we delayed our document submission. So the delays and the extensions are over. And right now we're in the process of collecting those documents. So July 1st, 2022 is our own internal deadline that we've set for our staff to collect all of our documents, making sure that we have everything in line. By August 1st, we will get a notification from the accreditation board. We call it our 90-day notice. It's time to start working on accreditation. And then by November 1st, we call it the HEDSI. That's our guidebook of what needs to be submitted. We will submit everything by November the 1st. And then sometime between January and March of 2023, so this time next year, we will have our site visit. And it may be a hybrid site visit. I think they're still piloting that. And so I wanted to give the board an update about, especially for our new members, about what is accreditation, where we are. So you will be hearing quite a bit about accreditation during these meetings in the next couple months. One of the new pieces with accreditation, so they gave us several extensions, and they also tacked on some new requirements for us. So one of the new requirements is about a tobacco policy. So as part of Medicaid transformation, Medicaid facilities are required to be tobacco-free. And so that impacts the health department across the state because we take Medicaid. Our health department facilities are already tobacco-free. We have an internal policy and procedure that requires our facility to be tobacco-free. However, this policy, based on our new accreditation requirements, now needs to be signed, not just by myself as the health director, but needs to be signed by the Board of Health. So we will have that for you next month to sign. There are also, along with this, the new 2022 accreditation requirements, It requires a little bit of an update of the language, which we have most of it in the policy, but we want to make sure the policy exactly aligns with what we're supposed to be doing. And so again, it requires that we're 100% tobacco-free facility, which means inside of our building. It also adds language about prohibiting our staff, or the health department rather, from purchasing or accepting donations or distributing tobacco products. We did not do that anyway, but we will write it in policy. And then it also requires us to have some language in there about promoting tobacco cessation, which we already do. We just need to write that into our policy. And then we need to update some of our signage to include e-cigarettes. So we will make sure that that happens. The next piece of that is not just having a tobacco-free facility, but our grounds also need to be tobacco-free. So North Carolina statutes, and board members that have been with us a while will remember some of these conversations about being tobacco-free, not just in our building, but on our grounds, where North Carolina statute gives local health departments and the Board of Health the ability to prohibit tobacco products in and around health departments. The board also has the authority, with the approval of the county commissioners, to approve regulations that make government buildings, grounds, and other public indoor spaces 100% tobacco free. But again, that's with the approval of county commissioners. And so this activity about tobacco-free grounds, we also need to make sure that has the most recent language about what defines a tobacco product, which includes any, not just traditional cigarettes, but includes any tobacco-derived product, vape product, or components of vapor products, so any forms of e-cigarettes are also included that based on the new general statute definition. So what does that mean for this board, and what does that mean for the actions that we need to take? The tobacco-free facility we are already doing. Our grounds are tobacco-free, but it means that we need this board to sign off on that policy. Again, previously it was just an internal policy that we have. It really needs to be signed by the board. So we will have that for the board to consider in April. And it needs to address all of our health department facilities. And so that includes actually now with our updated accreditation language, not just our physical buildings, but our mobile units as well. So we purchased a mobile unit last year, so we need to actually make the policy apply to our mobile unit as well. And then we'll update some signage there. And then also we clarified in the policy that the grounds, we also occupy a portion of the historic courthouse. And so the policy will apply to the portion of the courthouse where our environmental health staff are located. So we will update that policy language. We will have it for your review and consideration in April. And then we'll update our signage accordingly, including getting signage for our mobile unit as well. So any questions about that part? The primary action for the board will be next month to review that policy.
I need to tell you that the Board of Commissioners in the past have had stringent discussions.
Yes.
About that.
Yes.
That policy. So,
Yes. So that's why we're taking. Yes. So Commissioner Council said yes. This has been a topic of discussion in the past. So that's why the first step needs to be Board of Health approval. And then in terms of the health department internally has the ability for our own facilities. The challenge is the grounds, not just the health department building. And so if that's something that the board would like us to pursue, of course, in collaboration with the commissioners, we can certainly think more about the grounds. And our grounds currently are tobacco-free because they, except for the courthouse, they don't occupy, nobody else is on our ground and on Ramsey Street or in Hope Mills or Spring Lake. In our mobile unit, it's just us in our mobile unit. So that the courthouse is probably where we make it applicable to the area that we occupy in the courthouse. I'll note, though, that the county buildings are already smoke-free. So we're differentiating here between smoke-free and tobacco-free to get down in the weeds for you. So the county buildings are already, and grounds are already smoke-free. This is really about all tobacco products, not just the traditional cigarettes. Questions that we can answer? And Ashley Curtis is our deputy director, and she is a tobacco expert. And this board has heard from Travis Greer, who is our regional tobacco coordinator as well. A few dates, if there are no questions there, we'll have more information for you next month. A few upcoming events, Vax Your Pet, Vax Yourself is next Saturday. We started this back in the fall. We had our inaugural Vax Your Pet, Vax Yourself event where you can get rabies vaccines and COVID vaccines and back to school vaccines and flu shots. So we will relaunch that next Saturday. That'll be from 10 a.m. to 2 p.m. We have, that's funded in part by the Cumberland Community Foundation, as Candy mentioned. And then Cumberland Health Net is actually offering $50 gift cards for folks that get their COVID vaccines. And then our health ed team is also doing a Tuesdays in March into Better Health webinar series this month. It's Tuesdays at 6 p.m., so it's going on right now. And then it will continue every Tuesday in the month of March on different health topics. The National Association of Local Boards of Health, their annual meeting is in August. It's August 1st to the 3rd in Grand Rapids, Michigan. So if you are interested in attending, please reach out to Kelly so we can help coordinate your travel. And then the NACO conference is in July this year in Atlanta. So if you're interested, there's a virtual option and an in-person option for that. So if you're interested in attending that, then you please also reach out to Kelly and we can help coordinate your registration. Dr. Ojo, that is all I have.
Thank you very much, Dr. Green. Do we have any comments or questions for Dr. Green, please? Thank you, Dr. Green. That was a lot of information. At this point, I will implore board members to please review the attendance roster on page 24 and communicate any discrepancies to Ms. Kelly. The floor is now open for board members' comments, please. Do you have comments, please, or questions from board members? If none, I would like to remind us to please sign the attestation statement that you have received a copy of the 2022 Board of Health Handbook and fax or scan it to Ms. Kelly, please. Thank you. The next regular board meeting is on Tuesday, April 19th, 2022 at 6 p.m. May I please have a motion to adjourn this meeting?
Move that we adjourn.
Motion to adjourn.
Thank you. Second?
I second the motion to adjourn.
Thank you. All in favor?
Aye.
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 Thank you all and be safe.